on and do ask me questions at the end.
Yeah, we are.
Okay, so if you have diabetes, you spend around 3 hours each year with a healthcare professional, and that's if you're really getting exceptionally good care, because most people won't spend even that long with a healthcare professional. And so you've got 8,757 hours on your own to deal with type 1 diabetes. And that's the next bit of it, Romain. So patients really need to be able to understand how to manage the condition. And that's the job that I do. I spend most of my time with patients with type 1 diabetes. Type 1 diabetes is very different from type 2 diabetes. And I think we've got a little video from Diabetes UK that just shows us what type 1 diabetes really is. Thank you, Romain. I think that's the next slide.
Yeah.
If the video won't play, don't worry. Romain, the last video I really need to play.
Oh, you want the video played?
No, it's fine. Don't worry about that one. It's okay.
Okay.
But if you could make sure the last one works, because that's really important.
Okay.
And the rest of them I can just share with her. You can have you've got the slides afterwards, and you can watch them afterwards.
Okay.
So type 1 diabetes is different from type 2 diabetes, because type 1 diabetes means you don't have any insulin apart from the insulin that you make yourself, that's given to you. So if Romain, could I just go back to that that slide with the cell?
Yeah, that's it. Yeah.
So that's lovely. Thank you. So what happens is that insulin is the key, and it opens the door to let the glucose into the cell. And without insulin, the body cannot get any of the glucose if you have type 1 diabetes. Now, if you have type 2 diabetes, your body can make a bit of insulin, so some of the glucose goes in, but depending on how big the cells are and how much insulin you're able to make will depend on how much insulin you actually get from your body. But in type 1 diabetes, you don't make any insulin, and so there's no glucose going into your body. And that's really is a fundamental difference. Dr. Anderson, who we work with very closely, would say if you put people into a room with type 1 and type 2 diabetes with a whole table full of food and left them for a week, at the end of that time, the people with type 2 diabetes would have a lot of glucose in their blood, but the people with type 1 diabetes would be dead. So it's a very serious condition. Okay, next slide. Thank you. And I'll have the whole of that slide. Thank you. So people with type 1 diabetes, have a lot of things to actually think about. They have to dose adjust the carbohydrates. So they have to work out how much carbohydrate is in every single meal that they eat, every single snack that they eat. And they may have to give insulin for protein if they're particularly sensitive. They have to check their blood glucose all the time. And they have to be really careful if they're sick, because they'll need more insulin. And they have to watch physical activity, because if you do very strenuous activity, it puts your blood glucose up. But if you do a long walk or a run, it will take your blood glucose down and you're at risk of hypos. And alcohol is another thing that they really have to watch, because alcohol can either put your blood glucose up if you have things like sugary cocktails, things like that. But if you had something like a spirit with a slimline mixer, it can put your blood glucose down. So all those things you have to take into account. And we say to patients, it's really like having a second job. You have to be on top of it all the time. The next slide, please. Thank you. So this is what happens if you don't have diabetes. You have a background amount of insulin that's produced from your body. And those are the lines that are at the bottom, apart from the peaks. And then when we eat, our body realizes that actually we need insulin. And so it produces insulin from the pancreas, from the beta cells. And you get these spikes of insulin that covers the carbohydrate that we're eating. And the next slide, please. And this is what we hope to replicate when we give insulin to the patients. So that kind of curved half circle is the basal or long-acting insulin. We usually give it at night, and that will work for between 16 and 24 hours, unless you have the very new insulin, which is called Tresiba, which lasts for about 5 days, and you just top that up. And then when you eat, you have rapid-acting insulin, and you need to take that 20 minutes before you eat. So this is called MDI, or multiple daily injections. So it's a lot to think about. Imagine having to take your insulin 20 minutes before you eat. That requires a lot of planning. And the next slide, please. So the background insulins, the basal insulins, are Lantus or Basaglar, and Levemir, which needs to be given twice a day, and Tresiba, which is the very long-acting insulin, Humulin I, which is kind of a 16-hour insulin, and Insulatard, which is again about a 16-hour insulin. So some people may need to take those shorter acting insulins twice. And NICE recommends that you have Levemir, which is a twice a day insulin. So that's 2 injections just for your background. And then when you eat, you need quick acting insulin. And that's the next slide. Thank you. So some of these insulins will be very familiar to you, and some of them probably not quite so familiar. So NovoRapid is standard, I think, across the world, and Humalog again. Apidra, maybe not quite so much, and Fiasp is very new. So Fiasp is a much quicker acting insulin. You don't need to take it 20 minutes before you eat. You can take it just as you eat. So it makes life a little bit easier. And then there are the soluble insulins, which are much cheaper, and are probably more familiar to some of you. So things like Humulin S, which lasts for about 6 to 8 hours, ActRapid about the same, and Insumin Rapid about the same. Now, you can't give those injections with snacks because they last too long and you're going to have an overlap of insulin. But if you're having the quick acting insulins, then you would have them with your meals and any snack that's over 15 grams of carbohydrate. So if you had a packet of crisps, you would need an extra dose of insulin. If you had a piece of toast, if you had 2 digestive biscuits, you'd need extra insulin. So it's a lot of injections in a day. So most people are going to be having 6, maybe 7 or 8 injections in a day. And the next slide, please. Thank you. So this just shows us the profile of the insulins, and they are all very different. I'd like you to look at the NPH, Insulatard or Humulin I, because you may have patients who are on that, and it's much better to give that insulin in the day, because if you look at the profile of it, its peak action is probably at 4 to 6 hours, and if you have that at night, then you've got no foods going in and you might hypo overnight. But the other insulins, the other long-acting insulins, we'd recommend that you had them at night. Lovely, thank you. And the next one. So you're going to eat, and you need to think about how many carbs are in the meal that you're going to have. Much easier if you're cooking from scratch at home or eating something that's pre-packaged, but very difficult if you've gone out to a restaurant because you don't know what's in it. And the pre-meal blood glucose. So most of our patients would like to have their blood glucose running at about 7, and so they will have a correction factor that's added in to their total dose of insulin. And the next slide, please. And I think there should be a ring that goes around the 1 to 10. Maybe not, maybe that won't work. But the rapid acting insulin, you have a carbohydrate ratio which we work out with the patients. If we don't know, then we'll usually start with a 1 to 10, which means that 1 unit of insulin covers 10 grams of carbohydrate. So a baked potato might be 60 grams of carbohydrate, so you'd have 6 units of insulin for that. Thank you, Romain. And the next slide. And the next one. Oh, okay. So if you're going to have a packet sandwich that has 40 grams of carbs in it, and your ratio is 1 to 10, you're going to need 4 units for that. And if your ratio is 1 to 5, then you're going to need 8 units for that. But they're quite small doses, aren't they? Because people with type 1 diabetes need very tiny amounts of insulin. They're very sensitive to it. And now we're going to look at the correction factor or the sensitivity factor. So if we're starting someone off, then we'll usually start with a 1 to 3. So 1 unit of insulin will drop their blood glucose by 3. So if they were 13, 1 unit would bring it back to 10. And lovely, thank you. So if the blood glucose target is 7, then if you've got a 1 to 3 and your blood glucose is 10, then you're going to use 1 unit to bring it back to 7. Thank you. And the next one. So now we're going to put it all together. And we're going to look at this very tasty food. I expect you're all getting hungry. So we've got some spaghetti in there, and we've got some meat and some peppers and things like that. And there's a lovely app called Carbs and Cals, and that works out exactly how many carbs are in lots and lots of foods. It tells you the weight, how many calories, and how many carbs are in it. So there's 51 grams of carbs, and we're using a carbohydrate ratio of 1 to 10. And then the blood glucose is 10, and we've got a correction factor or an insulin sensitivity factor of 1 to drop by 3, and we want to get back to 7. So how many units of insulin are we going to need? Anybody brave enough? Okay, so I make it 6 units. Let's see what it says. Thanks, Romain. So yeah, 5 for the pasta and 1 for the correction and 6 units in total. So imagine having to do that every single time you eat, and that's what we're asking of our patients with type 1 diabetes, because if they misguess the carbs, they can be either hypo or miles too high, and that's really difficult to manage. Lovely. And the next one, please.
Wow.
So we now know that actually giving the injection of insulin in the right way is actually just as important as the type and the dose of insulin. So insulin should be given at a 90-degree angle just below the skin, and patients should always do a 2-unit air shot because the pen may not be working, and if they don't do that, they won't know if it's actually going to go in. And the next slide, please. Thank you. Oh, yes, you can leave it on this. No, it's fine, you can leave it on that. Lovely. The picture is fine, Romain.
Picture, yeah?
Yeah, and I'll just go through it. So I found this really shocking, that this is a new needle at the top, and this is a needle that's been used a few times, and look how bent it is. And you can see what sort of trauma that's going to cause. So it causes hardening and scarring at the in the skin, and it causes the formation of lumps, and we're going to look at some pictures of that in a minute. So one needle, one injection. The patients get really worried because they think that they're causing the NHS to spend lots of money and that they should reuse their needles, but it's false economy, a new needle for every injection. And the next one, please. So people get to the point where they want to use just one particular place to give the injection. And they get these lumpy, fatty deposits, and it stops the insulin being absorbed. So it's really important that injection sites are moved around, and we're going to have a look at where the insulin can be injected. And the next slide, please. So these lumps that you can see there, one on the tummy and one on the side of the leg, it means that the insulin won't work if it's injected into that. The skin is damaged and hardened. But if the patient knocks that area, there's a whole load of insulin that's just sitting in a pool, and it will get knocked into the system, and then the patient has a really bad hypo because that insulin is suddenly going to be absorbed. And there's a patient that the next one is a patient, I think it might be my patient, because I remember seeing this patient and I was completely shocked when I saw their abdomen. So if we could have the next one, please. So these two lumps, these are areas that have just been used and used and used. And if you think you bang those areas against a kitchen work surface, because they're just at that right height, you're going to get all the insulin that's actually sitting in there absorbed into the body and cause lots of problems. And the next slide, please. So we used to think that there were slow areas and fast areas, but really that's not the case. It is dependent on the injection technique. But it's really important that if the patient uses a new area that they haven't used before, that they're very careful. They either reduce the dose or they check really carefully, because new sites will absorb much, much, much better than the old sites. But these are the right sites to use. We don't ask people to use their arms because that doesn't seem to be a very safe place to use. And the next slide, please. So when you give an injection, it has to be held in for 10 seconds. You'll often find that patients will give the dose, whip the needle back out, and there's insulin still dripping off the end of the needle, so they haven't got the whole lot. And if you're only having 4 units, you can have lost quite a lot of that insulin. So if you hold it in for 10 seconds, you'll get the complete dose. And the next one, please. Now, I don't know whether you've been in a restaurant and watched somebody give an injection through their clothes, but our patients do it all the time because they don't want to have to go to the loo. And I completely get that. Loos are often not very clean and you don't really want to be giving an injection in a loo. And they're embarrassed to give their injection in public. There are lots of clothes now that are made by Hidden and by other manufacturers that actually have gaps so that and poppers so that you can actually put an injection in without going through the clothes. And if you do put a needle through your clothes, you take fragments of the fabric actually injected into you, and they've done CT scans of patients who do this all the time. And there's just lots and lots of layers of fibres actually underneath the skin. So if you see patients doing it, please try and get them to not do it. It becomes a habit and it's quite hard to get out of. Lovely, thank you. And the next one. So storage of insulin is really important. I want to tell you about a patient that we saw last week. So the patient came to the unit very, very upset, saying that we were giving him insulin that didn't work and he was in a complete state, very angry, very upset. And when we talked to him, he had been made homeless and was sleeping in his car, and he'd put the insulin in the door of the car. And the insulin had got so cold that it wasn't working, and that's why his insulin wasn't working. And when we gave him new insulin, and we haven't sorted out his housing yet, we're trying very hard, but got him to put it next to his body and to sleep with it actually on his chest. It will keep the insulin warm enough and it won't freeze, because if the insulin gets too cold or too hot, it won't work. So can you use it if it's expired? No, it won't work. It slowly stops working. And it's really important to check the insulin, because sometimes it hasn't been stored correctly on the way from the pharmacy or from the manufacturer, and it might be cloudy when it isn't supposed to be, or it could have lumps in it. And if you're not sure, throw it out. Insulin only lasts for a month out of the fridge, so get patients to write the date when they take it out on the vial or on their pen, so that they know and don't keep using it once it's expired. There are things like Frio wallets that they can put their insulin in to go to the beach, and that will keep their insulin at perfect temperature, and it won't go out of date. It won't stop working. Lovely. Next slide. So how do we check to see if patients are managing to do all the things that we've asked them to do? So we check that something called their HbA1c, which is a blood test that looks at their blood glucose over the last 3 months. The lower one has just a few dots of glucose on it, so that's probably an HbA1c of about 7%. And the top one has lots of bits of glucose on it, and that's probably an HbA1c of 12%. So we really want to get our patients with lower HbA1cs, especially in these times of COVID, because we know that patients who have type 1 diabetes and poor control are much more at risk from COVID, not of getting it, but of not doing well if they do get it. And the next slide, please. And I've talked through this, so the next one, please. So we use percentages. I don't know what you use. You may be very modern and use the millimole per mole. If you've got somebody who has got an HbA1c and you want to know what it is in the new money, then all you do is, if it was 8%, then you take 2 away from the 8, that gives you 6, and then 2 away from the 6, and that gives you 4. Which means that in the new money, it's 64 millimoles per mole. So that's a good way of knowing how to convert it either way. Okay, thank you. And the new one, the next one, please. So these are our aims of treatment. So if you're seeing patients in clinic or on the wards, then we're aiming for an HbA1c of about 7.5%. The NICE guidance says 6.5 to 7. That's very hard to get to 6.5 to 7. But if you're pregnant or want to be pregnant, somewhere between 6 and 6.5 is where we really do need to be, because that prevents the complications. And if you're older, then we're aiming for 8%, because the last thing we want is somebody having a hypo and falling and breaking their hip, because that would be even worse. And for patients, they need to be pre-meal between 4 and 7, and post-meal under 9 if at all possible. I'm not going to talk about CGM and Libre, but maybe in the future you might want me to come back to talk about the new technologies. But this is where we're heading, and time in target is going to be the new HbA1c, and we want that time in target around 70%, so 70% of the readings between 4 and 10. Thank you. So I'm going to talk about hypoglycemia. Hypoglycemia is very frightening to patients. They have often, if they were diagnosed when they were very little and a long time ago, when they were in hospital, they were forced to have a hypo so that they knew what to do. And that's a really scary thing to do to a child. And I hope that doesn't happen anywhere anymore because they feel really very frightened when that happens. So Diabetes UK says 4 is the floor, no blood glucose levels below that. And if people have frequent hypos, they lose their sensitivity, and so they don't know when the blood glucose is low. And the next one, please. So everybody will have different hyposymptoms that they know are their hyposymptoms. So it could be that they feel really shaky, or they could feel sweaty, or they could have tingling around their lips, or they could be very hungry. But most people will have something, and we're just going to go through all the symptoms that people might have. And these symptoms will change over time because as people live longer with type 1 diabetes, they become less sensitive to it. Thank you. And we'll have them all up. That's lovely. So this is a Diabetes UK slide, and these are the autonomic symptoms that people might have. So one of the ones that I didn't talk about is anxious or irritable, and often it's the partner who knows that they're hypo, and that can be very tricky because they might say to the person with type 1, oh, I think you're hypo. Well, it's the person with type 1 diabetes, it's their diabetes, they don't want anybody telling them that they're hypo. So often we say to patients, family or friends, it's a good idea if you notice it, just to say, oh, should we have a cup of tea and a biscuit? Because that will often be enough to actually get them back up again. Lovely. And the next one, please. And the next one. Thank you.
Next one, yeah?
Yes, please. Thank you. So these are the neuroglycopenic ones. So palpitations and a fast heart, lack of concentration, very tearful, a headache and tiredness. Tingling of the lips is actually usually one of the first ones that people get. But yeah, all of these, you imagine that you're not able to concentrate and you feel really out of sorts. It's not a nice feeling. And the next one, please. So we used to have a patient at Barts who would come to clinic and we'd see him walking round the waiting area. I don't know if any of you've watched Monty Python and the Ministry of Silly Walks, but he would be marching around the waiting area and we would know that he was hypo. And so we'd go out, give him some Coke and get his blood glucose up. And he would do it almost every single clinic visit, and there was nothing we could do to stop him running his glucose levels so high, so low. And the next one, please. So, oh, thank you. So you need 15 grams of carbs to treat a hypoglycemic incident, and we say there's a rule of 15. So 15 grams of carbs, quick acting carbs, and then wait 15 minutes, check again, and then 15 grams of long acting carbs. So the government with its sugar tax has meant that the amount of glucose in things has changed. So you need to be very careful. It used to be a third of a bottle of Lucozade contained 15 grams of carbs, but now it's half a bottle. And you need to watch as they change the amount that's in there to make sure that it still is 15 grams of carbs. So people think you need chocolate or you need something else, but actually you only need quick acting glucose. If you have chocolate, it has fat and that slows the absorption down. So you won't absorb it quickly enough and your blood glucose will continue to fall. And the next one, please. So this says 3 jelly babies, but they've changed the amount of glucose in jelly babies. So you now need 4 or 5, and 5 sugar lumps or 3 teaspoons of sugar. So a patient rang me up the other day and he said he was hypo. He'd just gone home from hospital. And I said, oh, have you got some sugar? And because he didn't have any of the other things, and he didn't even have any sugar, he had to go and borrow some sugar from a neighbour so that he could treat the hypo. So sugar is the thing that most people will have in the house. And so trying to get people to keep some sugar, because 3 teaspoons of sugar in some water, some warm water, will bring the blood glucose up, or in black tea or black coffee. But if you add milk, it slows down the absorption, so they can't have that. And the next one, please. So check 15 minutes later, make sure that it's above 4. And if it's above 4, then they can have the long-acting carbs. And that's the next slide. So rich tea biscuits or digestive biscuits are perfect. If you're going to eat in 30 minutes time, if the patient's going to have a meal on the ward, that's completely fine. A slice of bread, doesn't matter what kind of bread, all bread has 15 grams of carbs in it. But if you have white bread, you need to have butter on it or margarine, because otherwise it's too quick acting. Or a piece of fruit. So any of those, apple, pear or peach, have 15 grams of carbs in them. And then we've got some other examples in case people are not able to swallow quite so easily. So remain the next slide, please.
That one?
So for people who have got problems chewing, then some yogurt or some milk would be perfect. So plain yogurt, 100 grams, but only has 5 grams. So you need to have 300 grams of plain yogurt. But a fruit yogurt has almost 15 grams of it. So you wouldn't be too far out. And a 300 ml glass of milk will have enough. And that's a standard size glass. Perfect. And the next slide, please. So I'm going to talk about glucagon, and then I'm going to share the video that you can watch later, because I think otherwise we will run out of time. So glucagon is an emergency injection that can be given by a family member. It's carried on all London ambulances and all paramedics. And it's given into one of the big muscles. So either the muscle on the side of the leg or into the back of the bum, so upper outer quadrant. It will raise the blood glucose levels in 20 minutes time, but it causes projectile vomiting, so always put the patient on the side. And if you don't give them a carbohydrate snack later, once they are not feeling sick, then it will drop again. And then we've just got a picture of it because it comes in a kit, and patients have to be, their relatives have to be taught how to use it, because in an emergency situation, they're going to have shaking hands and they're not going to feel confident. Could we have the next slide, Romain, please? And if we, yeah, lovely. So it has water for injection that you inject into the powder, and then you have to mix it up, not shaking it, because that causes bubbles and it won't be very easy to inject. And then it goes into one of the big muscles on the side of the thigh. But it's not easy to do, and if you're anxious about your loved one, it's quite hard to do. So we train our patients, family and friends to be able to give it so that they could do it in an emergency. It has a short half-life, a short shelf life. So they need to make sure that they have always got one in date. And if you've needed to give a glucagon injection, you're going to need probably to give another one, because the liver will have exhausted all its supplies of glucose, and the patient's very likely to have another hypo within the next 24 to 48 hours and have no stores left. So you'll need to give it again. Lovely. And the next, and bypass the next one and the one after that. Sorry, my dogs are making a noise. I'm just going to let them out. What's wrong, Bridget? Out you go. Out you go. There we go. Out you go. I think it must be supper time for the dogs. So what's happening is that the body is recognizing that the glucose levels are falling, and there are 4 hormones that are involved in this. So glucagon is the alpha cells in the pancreas secrete glucagon, and this signals the liver to produce more glucose. And then epinephrine is secreted by the adrenal glands, and that signals the liver and the kidneys to produce more glucose and stop some of the muscles taking up glucose, because our muscles take up glucose all the time. And then if the body can't produce enough glucose, then the growth hormone and cortisol are secreted to try and get the body to produce more glucose. But it really is quite a scary feeling for people, and there's a lot going on. And the next slide, please. So there's always a reason why the blood glucose falls, and it's so important to find out what it is that's caused it so that it doesn't happen again. So if you eat less than you plan to, so say you've taken your insulin and you get given your meal and you don't like it, then you've taken the insulin, so you're not going to have had enough food. You need to eat something else to make up the carbs. So sometimes if you go out to a restaurant, and restaurants are particularly difficult, then you may have misjudged the amount of carbohydrate that's actually in the food that you're going to eat. Often it's too much carbohydrate, but sometimes it's too little. If you give the injection at the wrong time, so a famous one is porridge oats. People think porridge is completely healthy and a fantastic breakfast. Actually, it really is very difficult to eat porridge if you've got type 1 diabetes, because the insulin works very quickly, but the porridge is really slowly absorbed. And so the insulin has been and gone, and it causes you to hypo. And then the porridge goes into your bloodstream and your blood glucose goes up. And so we get something called the tick effect. So drop, and then it spikes up again. Exercise. As I said, exercise can sometimes make your blood glucose go up if you do really high intensity. But if you do low intensity, then your muscles will take back the glucose. Sometimes they take it back immediately. Sometimes they take it back 24 hours later, and you really don't know when it's going to be. If you lose weight, the cells get smaller, and so you don't need so much insulin. And if you drink a lot of alcohol, it's the only time when you could die from having hypoglycemia. And that's because your liver recognizes alcohol as a poison, and it will deal with the poison. It takes your liver 1 hour to deal with 1 unit of insulin. And so if you drink a lot, take your insulin, go to bed and go to sleep, it is possible that you don't wake up. And so we will say to our patients, have a snack of something before you go to bed. Take only half of your background insulin if you've had a lot to drink. You can always correct it in the morning, but much better to be safe than sorry. Lifestyle changes. So things like going hiking for the day, gardening for the day, doing painting and decorating, all use loads of muscles, and you're likely to hypo. And if your meter isn't working, then it can give you a wrong number, and then you treat based on that. And as we mentioned before, that lipohypertrophy where you've got those lumps and suddenly you get all the insulin. And the next one, please. So for people who've got type 1 diabetes, their symptoms will change, and patients get very busy with their work. They're staring at a computer. They say, oh, I'll treat it in a minute, I'll treat it in a minute, I'll treat it in a minute. And then they don't treat it, and then they lose some of their signs and symptoms, and then they get really bad hypoglycemia. So we have a patient who worked for one of the big banks, and he was in a glass office. So everybody could see into the office, but he'd locked the door, and he became hypoglycemic and fitted inside the office, and everybody could see from outside, but they couldn't get in, and in the end they had to break the glass to get in. So it's most common if you've had diabetes for over 20 years, and 50% of our patients who've had it for that long will have some degree of impaired awareness. Next slide, please. So there are things you can do to get it back. Our patients don't like it because people who are hypo like to have their blood glucose no higher than 7.5. They think if it's above 7.5, something awful is going to happen. But we say run your levels above 10 for about 6 weeks and the symptoms will come back. Don't have any alcohol and always have something to eat before you go to sleep. And then they should come back to what they were like 2 years previously. Lovely, and the next slide, please. Whenever we have a patient who usually comes to clinic on their own and they come with their partner, we know that it's almost always the case that they're having nocturnal hypoglycemia. They're not aware of it, but their partner is aware of it because they're having very vivid dreams, or they're very sweaty, or also they're having nightmares, they're getting up in the night, and it's stopping their partner sleep because their partner's so worried about them. So if we think that somebody's having nighttime hypoglycemia, we get them to drink 2 pints of water before they go to bed, because you're going to have to get up then at 3 o'clock in the morning, check their blood glucose when they wake, and if it's below 4, then we will reduce the background insulin and keep on reducing it until we stop the nighttime hypoglycemia. And we get them to think about all the things in their lifestyle that might be causing it. But it's quite difficult for the partners. And the next slide, please. So this is a lovely flow diagram. It looks busy, but it actually really does help. So we've been thinking about low blood glucose. So low blood glucose promotes glycogen release, we said, from the alpha cells in the pancreas, and that helps the liver to produce glucose, and then the blood glucose goes up. And when the blood glucose is high, the pancreas would release insulin, but it doesn't have any. But when the insulin is given, then the insulin is stored in the liver so that it can make glucose for the next time you need it. It's also taken up by the cells, so the kidney cells, the muscle cells, the fat cells, and that lowers the blood glucose. So that's what's going on with the insulin and the glucagon. And the next slide, please. So we've talked about lows, and now I want to talk about highs. So if any of you have seen somebody newly diagnosed with diabetes, then you will almost certainly have seen somebody in DKA, because they don't have any insulin and they get very high blood glucose levels. So I've seen a blood glucose level of 50, and patients lose weight. They're very thirsty, polydipsia, polyuria. They get infections, they can't see very well because those vessels at the back of their eyes are full of glucose, and things don't heal. And if that isn't treated, it leads to DKA, diabetic ketoacidosis. And the next slide, please. And could we go back? Thank you.
Back, yeah.
So glucose is a pure fuel. And if you have insulin and glucose, then your body will work very effectively. But it's a bit like taking your car to the petrol station and putting diesel in a petrol car if you don't have any insulin, because your body is looking for fuel, and it looks for fuel everywhere it can, and the place that it finds fuel is in fat, and that's why you lose weight, because the body burns fat. But fat is not a pure fuel. It has waste products, and it has ketone bodies that are formed, and it causes the body to become acidic. So the glucose levels continue to rise. The body looks for fuel and it burns fat. You produce ketones if you have type 1 diabetes, and then your body realizes that it's acidotic and very unwell, and it starts to get rid of the ketones by increasing the rate of breathing. And you get a pear drop smell. Some people can smell it, some people can't. I can't smell it, but some people on the unit will tell me, oh, that patient's got ketones, because they can smell it. And your body tries to get rid of the glucose by passing out as much urine as it can, and that causes dehydration, and the salts, the sodium and potassium are displaced, and patients collapse. So it's very serious. And the next slide, please. So what will people come into hospital with? They'll usually ring up, actually. Our patients have our numbers, and they'll usually ring to say, I think I might have ketones, and we'll give them some advice. But if they're new or they don't have anybody to talk to, then they'll find that they're very thirsty, they've got polyuria, they're very tired, they're not seeing very well. They may become confused and they can lose consciousness. And I have had to call an ambulance for somebody because I've heard their breathing is not good. And I thought, they're going into DKA. And I've told them to leave the front door open and call an ambulance so that they can come into hospital. They get something called Kaufman breathing, which is where you get sighing breath because the body's trying to get rid of the ketones. They get stomach pains, they may vomit, and they'll have the pear drops on their breath. And the next slide, please. So just like hypos, there's always a cause. So we have lots of patients who don't take their injections. Young people want to manage their weight, and one way of managing their weight is not to take insulin, because insulin is a growth hormone, and they find that if they they can eat whatever they want and don't take insulin, the weight will drop off because they're burning fat. But obviously that's very dangerous. If their insulin's gone out of date, if they've kept it out of the fridge too long, if the pen isn't working or their pump isn't working, and if they're very sick, or if they have something like a heart attack or a stroke. So an infection is probably 30 to 40% of people results in the reason for it. And a heart attack or a stroke, probably about 1%. And 25% are because people are not compliant. So we want people to have tight control of their blood glucose because that means they're not going to run into trouble. And if they're sick, to take their measurements much more frequently, so every 2 hours, and to keep taking insulin, because often they think, well, I'm not eating, I don't need any insulin. They really do. If they've got diarrhea or vomiting, or they can't drink, they need to go to A&E because they're not going to be able to flush out the glucose. And they need to check for ketones. So we ask our patients to check urinary ketones, but some patients will check for blood ketones. So blood ketones above 3 millimoles and urine ketones above 2 to 3 pluses. and they must keep taking correction doses and keep taking their insulin. And the next one, please. So when you're sick, your body makes those counter-regulatory hormones, and they act as a brick wall against the insulin and stop it working. So you actually need more insulin when you're sick, not less, and people tend to take less. So that's a really important thing to say to people, you need more. And the next one, please. And these are the sick day rules that we give to patients. So you're welcome to use these if you've got people with type 1 diabetes. It's a very good way to actually make sure that they stay safe, because obviously it's a very serious condition to get DKA. Sometimes no matter what you do, you can't keep people out of hospital, but hospitals are dangerous places to be. You often pick up things when you're there, so much better to keep people at home if you possibly can do. And the next slide, please. So complications, this is the bit that worries patients the most, and it's the biggest driver of behaviour. So we need to be really careful in the things that we say to patients. So we have patients who have been told when they're small children that if they let their blood glucose run high, then bits of their body are going to drop off. And these are the patients that now have such problems with hypoglycemia because they are terrified of letting their blood glucose run high. And so they will keep their blood glucose low all the time. So we need to be really careful in the language that we say. And we also have patients who don't want to tell us the truth, because when they were children, they went to clinic and they sat in a room with about 4 or 5 other people, and they were deemed to be the naughty kids if their blood glucose was high. So they learnt to lie, and they always said their blood glucose was fine. And then people didn't realise that it wasn't okay until they had their HbA1cs, and that's 3 months down the line, 6 months down the line, maybe a year down the line if they blocked having those blood tests done. So really important to listen to the patients and use language that is very non-judgmental. So complications are scary, and many patients will lead a life without complications if they keep their blood glucose well controlled. So there are 2 main types. So damage to the walls of the small blood vessels, which can cause damage to the eye, to the kidney, and nerve damage. 20 years ago, 30 years ago, you'd see lots of people with white canes, and those patients often had diabetes, poorly controlled, and they'd lost their sight. We very rarely see people who lose their sight now because of diabetes, and that's because of the amazing treatment with lasers and the new technologies that are actually coming through. But people do still need kidney transplants and end up on dialysis if they don't manage their diabetes. And they can get nerve damage to their feet and to their hands, and that can mean that they lose sensation and then damage their feet, walking on hot sand, not realizing it's hot, or getting things like drawing pins into the bottom of their feet. And then the medium and large size blood vessels get fed up, and so you get heart attacks and strokes and blockage to the arteries in the leg. And the next slide, please. So what can we do? So we need to get our patients to stop smoking. We need them to get their blood pressure to be 130/80 or below, and reduce their cholesterol, their total cholesterol, to 4 or below, or the LDL to 2 or below. And the next slide, please. Depression. So depression is a huge problem for diabetes. You imagine you've got all those things that you've got to think about, as well as your everyday life, and eating disorders, because every single time you want to eat, you've got to think about the carbs. And so it's much more common to have an eating disorder in men and women with type 1 diabetes. And the last slide, please. Romain, could you play that video? That would be lovely. Thank you.
Type 1 diabetes, and I've had it since I was 2. I'm now 29. As a teenager, when it got really, really difficult, started experimenting with insulin. Obviously, I could feel that I was having high blood sugars, but I noticed that I was losing weight dramatically, which as a teenage girl felt quite good at the time.
It's relatively common for us to see people disengaging from their diabetes treatment. It's often people in their teens. At that age, it's one of the most difficult times of life. You've got a lot of peer pressure to conform to certain ideals in society and things like that. So it's very easy to want to ignore diabetes.
Seeing a psychologist can be really helpful if you're feeling stuck and frustrated with your diabetes. It doesn't mean you've got a mental health problem if you're seeing a psychologist. Chronic health conditions are very difficult to manage and cope with, and many people benefit from seeing a psychologist.
Before I was diagnosed, for many years there was indications that I was diabetic, but I took absolutely no notice. Still to this day, I haven't really accepted it. But very hard to digest. I carried on for years and years, paying no attention to what I was told would happen.
People with type 1 diabetes don't want type 1 diabetes, so they often then close their eyes to it. But certainly as our role, it would be to try and bring the person into a place where they can deal with their diabetes, so therefore lessen the risk of the complications of diabetes.
My dad's actually type 1 diabetic as well. We'd have regular meetings, he'd help me with my blood sugars and what dosages to give. My mum would always check as well and just check that I'm doing my blood sugars, and would just say, yeah, I'm doing them, I'm leaving right in range. So they were supportive as what they could be, but I was still quite lying to them about it. I think it was a psychological condition, but I wasn't aware of that at the time. I genuinely felt like I would just get away with it. That's how I felt.
A lot of patients feel that they're not coping well with their diabetes, feeling that they're failing, and that can mean that they look after themselves, engage with their diabetes much less well.
Difficulties managing diabetes can lead to lots of complications. We think particularly when patients have had poor control for a long time, that can affect their eyes, it can also affect their kidneys, and affect their feet as well. If people have had type 2 diabetes particularly, but also type 1 diabetes, increased risk of having heart disease, stroke disease, and leg ulcers as well. I stopped working just over a year ago. That wasn't through choice. I started obviously going downhill out of work maybe a year before I finished. Spent a lot of time hiding away in the office. I became a bit of an office manager, not doing anything, sleeping, believe it or not. How could I get away with that? I just locked the door and I'd make sure no one ever bothered me. I didn't know what to do. You know, I had to provide for my family, I had to pay the bills. It's survival management. That's basically what I did. Hid away.
The sort of impact that complications may have is that people may need to attend more hospital appointments. For instance, if they need to go to their eye clinic, they might need to have treatment of their eyes, and they might suffer some degree of visual loss. They may get problems with the nerves affecting their gut as well, which can cause vomiting and diarrhea and things like that can be quite intrusive to everyday life. Between 2011 and 2012, I started experiencing my first complications. So I'd have some tummy issues where I was being sick quite a lot, and I'd get the frequent pains in my legs, and I was diagnosed with gastroparesis and nerve damage in my legs. Still didn't really take much notice, but it was 2016, and I woke up with a blurred eye. My right eye was blurred, and I went to the eye hospital
and they told me that I had a retinopathy bleed, and they sent me for emergency surgery the next day. And that's when my life completely changed. For 7 months was a massive battle where I had 7 eye operations in 7 months, and as a result of that, I am now blind in my left eye. So that was a really tough year. And then it went on to 2017 with eye injections as well. So that was a really tough time.
I'm now currently sitting at 30 eye injections. That's 30 each eye. I have lots of nerve damage throughout both legs. I now have no working kidneys, no working pancreas, and have dialysis at the moment 4 times a week due to not being able to clear any fluids. And a very tired life. Not the best situation to be in.
I was physically blind for up to 6 weeks at a time. 6 weeks was the maximum time that I was blind in both eyes. I had to have training on using a white cane to be able to get around. My anxiety was huge because I couldn't go out the house, because there'd been a time where I'd been out with my friends and could see, and within minutes I was blind, so I just never knew when it was going to happen, when I was going to have an eye bleed. So I couldn't go out with my friends as much as I wanted. I couldn't go out with my boyfriend or see family as much as I wanted, or even keep in touch with them, texting and Facebook and all that sort of stuff. So yeah, it really took a battering on my psychological health at the time.
Every single person diagnosed with type 1 diabetes feels overwhelmed at some point during their diabetes life. We sit and we will listen to people, and we will explain that we're not there to judge, and we will explain that we're actually there to help them and to support them, and that actually, you know, nobody's perfect in life and we all make mistakes, and just to move them through that period of feeling the way they do.
I now have a heart, or identified heart disease. So that's now put me in a position where they don't think I'm strong enough to have a pancreas and kidney transplant. So it looks like just a kidney transplant. To have a kidney, to not have to go to dialysis at the moment 4 times a week, 4-hour sessions, it would be a transformation.
The complications have a huge impact on people's lives. Heart failure is increasingly recognised as a complication of diabetes, and an increasingly common complication, and that makes people breathless, it makes them tired, it makes them unable to do the job that they want to do, or maybe to enjoy their family life that they want to enjoy. So there are lots of ways in which diabetes affects people's ability to lead what we might consider to be a normal life or a healthy life.
It's just not the eye issues that I'm dealing with now. So I now have kidney disease, stage 4. And I'm now on a waiting list for a kidney and pancreas transplant. And they realised my kidneys were at 30% function, and they are now at 18%. The average waiting time, they said, is 12 to 18 months. I've already received 1 call already, so I just never know if I'm coming or going. But I know it's a massive positive, but it's a very scary journey at the moment that I'm on.
I don't know if it's because of the age I was. I'm at that age I felt bulletproof. I really did, you know, heart attacks, getting old, strokes, things like that. Couldn't happen to me. Ill health wouldn't happen to me. You know, I was thinking 10 years down the line, God, I'm so cool. It doesn't matter if I'm alive or not. You know, 15, 20 years down, I am now there, 15, 20 years down the line. I am still alive, and I'm paying for it now. I would do things different. Definitely do things different.
If you're struggling with your type 1 diabetes control, then we would want you to call us, make an appointment, email us, and indeed offer an open door policy to people that are struggling. Please come in, please make an appointment, and we will sit and have a cup of coffee and a cup of tea and a chat.
You're not indestructible. It will happen. it will. Inevitably, it will. No one's going to get away with it. If you don't crack on and look after yourself, one complication will appear, 2, 3, 4, they will keep coming. It will happen. I just feel like you should take the support that you get. Fight it. Try not to hide from it. Speak to people. If you feel that you are mentally struggling with it, speak to people, because that's the only thing that can get you through sometimes, is opening up, being honest, and you won't be in trouble. You'll be helped.
What we want to do is be the person who helps you get where you want to be. And usually we do that by trying to make small changes and small targets and helping you follow those through. And hopefully being the person who listens rather than the person who just tells you what to do.
You're not bulletproof. You do need to take it serious. Because I'm an example of how not to do it. And trust me, I'll swap you for your position anytime. I don't want to be in this position. And it's a situation I put myself purely down to people wanting and willing to help me. But I took no notice because it doesn't happen to me.
Diabetes is a marathon, it's not a sprint. So there will be some times when you feel really passionate and engaged and fully on board. There'll be other times when you feel washed out and exhausted. In a sense, I want to say that's okay. You shouldn't feel ashamed by that. We're not going to blame you about that. We're not going to judge you for that. This is about just coming along and sharing some of those burdens. And if we can help you, if we can unload some of those burdens, if we can give you a bit of advice that makes the diabetes just that bit more manageable, we would love to do that.
I have 2 young children, 10 and 12, a good wife. My future, it's not something that I really talk about much, a future. Do I have a future? I guess I do. A lot of it hinges on having a transplant.
For people who are struggling with their diabetes management, it's really important to reach out, whether that's through your GP, through a nurse or a diabetes doctor, to let them know, and they should be able to refer you in contact with sources of help.
Hopefully, after transplant, I have been told that if everything runs smoothly and there's no complications within a year, then I should be able to try for a family. So that's my main goal, and that's what's keeping me going at the moment. So hopefully in the future, after the double transplant, be back to a real healthy self and hopefully be able to start a family.
Thank you, Romain.
Yeah.
I'm very sorry that it didn't play quite as nicely, but if you missed any of it, I really urge you to actually have another look at it, because I think their voices are so powerful. And we run a group for friends and family of patients with type 1 diabetes, and we played that video for them, and they could then see why their loved ones were so worried about the complications. And it takes up a lot of space in people's heads worrying about it. So that's the end of my presentation. I hope it's been helpful. I'm happy to take any questions.
Okay, back to the audience.
So any questions for Laura? Please, let's try and use our hand button. So some of the comments from the chat, great presentation. Thank you very much. That's from Liz. So Elizabeth.
Well,
any questions?
Lovely. I think if there are any questions, then I will leave you to the rest.
I have a question. Okay.
Franca's hand is up.
I think yeah, there's some. Sorry, Romain. Romain, have you stopped sharing?
Yeah, I've stopped.
Okay, thank you.
The score, I'm still recording. Yeah.
Okay, thank you. We've got Franca, I think we've got a couple of questions, Laura, please.
Lovely.
Laura, thank you very much for the presentation. Please, can you help me just make me understand why is it that people with diabetes or type 2 diabetes, when they get sick, for example, like with COVID or any virus, their sugar level goes up?
Okay, so the counter-regulatory hormones, all those ones that we talked about, so the catecholamines and the growth hormones and the cortisol, they block the action of the insulin. It's like they build a brick wall against the insulin working. And so you need an awful lot more insulin to actually get the same result. And with COVID, so patients with type 1 diabetes are much more likely to have poor outcomes if they're poorly controlled than patients with type 2 diabetes. And we've noticed that with our patients with type 1 diabetes, that actually some of them are running very low blood glucose levels, and we're needing to shave off a lot of insulin, and we don't know why that is. But this has been noticed across London, that patients with type 1 diabetes are sometimes needing less insulin with COVID. But general illness, they need a lot more.
Okay. Thank you.
Thanks, Franca. Thanks, Laura.
Not at all.
My hand is up.
Yes, Rose, I was coming to you.
Okay.
Go on.
Okay. I'm not asking a question. I just want to say a huge, huge, huge thank you, to come and talk to us about diabetes, because we work in different areas of nursing. And so when we see diabetic patients, those who are not directly involved, the doctor is always seeing the patient and treating the patient. We nurses don't understand, and they don't know the complications. For you, who is specialized in diabetes, coming to talk to us, I mean, it's an eye opener. And so I'm really, really grateful that you came. Thank you very much.
Sure. I think, when I worked on the wards, I didn't know anything about diabetes. I didn't understand the insulin. I didn't understand how it worked. And so, yeah, I was thinking, gosh, if I was working on a ward or working in a GP clinic, this would kind of really help to understand what the patients are going through.
I had the same problem when I was working as a midwife. We could test the blood sugar and document. Until I went and did the diabetic course, I didn't understand much about it and how complex it is. Thank you very much.
So complicated in pregnancy because you become more insulin resistant as the pregnancy advances. You need more insulin. You can eat very little carbohydrate in the mornings because if you have carbohydrate, your body just can't deal with it. So yeah, it's a really tough ride. Yeah.
Thank you. It's a long time.
Not at all.
Thanks, Maros. Thanks, Laura. Just one comment from Eli. Yes, Eli, I think the slides are going to be put. We have the slides, so we can share them.
Yeah, you're
welcome. Just a quick question, please.
That's all right, Evodia, go on.
My hand is up. Laura, I've heard about type 1, type 2, and it's just been an eye-opener today, and I'm really, really grateful to sat and listen to you. But one thing that baffles me is how do you get the patients to understand the carbs and the calories? Do you give them a list, or is it an app? Yep. And if it's an app, what of people who don't have mobile phones that have got all these apps on? How do you do it?
So if you come to the Diabetes Centre, you will see that we have a room full of food. So plastic food, and we use these food models to teach the patients about carbs and how to measure the carbs. Because you're absolutely right. Where we work, we have a big Orthodox community, and they don't use smartphones. They don't use any technology. And so the Carbs and Cals app doesn't work for them. And so we have pictures and all sorts of different things for the patients so that they can get to learn about the carbs. And we do carbohydrate workshops so that we actually cook real food and weigh it and get them to estimate how many carbohydrates are in it. and we run courses for the patients all the time, so that they learn more about carbohydrates and how to dose adjust. Yeah.
There's also a book on carbs and carbs.
Yeah.
Yeah, I've put online so that it's just $12.99. Anyone who's interested can buy it, because you have Caribbean food, African food, Asian food. You know, it's very, very good. That's what I use at work.
It's an absolutely great book.
Yeah.
You know, if you can actually afford to buy it, it's fantastic. The app is
it's not expensive. $12.99. Yeah.
So the app is cheaper, but if you can't, if you don't have access to smartphones, then you're absolutely right. It's perfect.
Okay,
Thank you.
Laura, thank
Thanks.
you. I've got one more question in the chat from Ellie again. Sorry.
Can it be reversed? So you can't reverse type 1 diabetes unless you have a pancreas transplant. But type 2 diabetes, we have run groups at the Homerton using low energy diet, and we've had the patients with 800 calories a day for 12 weeks, which was shakes. They just had shakes, and we had a 90% reversal rate. So you absolutely can reverse type 2 diabetes, but you need to have had it for not more than 6 years. We think that if you've had it for more than 6 years, your pancreas doesn't have enough reserve to actually be able to cope. So our patients lost about 15 to 20 kilos. And after the 12 weeks, they have 2 shakes a day, and then they reintroduce 1 meal. And then after that, the next 12 weeks, they go back to a moderated form of normal eating. And so long as they keep the weight off, they will be in remission. The diabetes hasn't gone, it's still there. They go back to the old lifestyle, they will get it back. Okay.
Okay, thank you.
The meeting.
Can I just I wanted to say as well to Laura, because you know, the bumps in patients' stomach, those insulin sitting there. I never knew it was insulin sitting there. And you know, you just giving me a vital information today. If they get knocked out, then the insulin gets released into the patient. I never ever realized that there were a sack of insulin sitting in patients' stomach like that. You know, it was very, very good to know that. Very good.
Oh, not at all. Thank you so much.
Sorry, Laura. Before we leave you go, Ellie, you seem to have a lot of questions, which is really helpful. Ellie's asking about the food plan. Ellie, do you want to just say what your question is, just for Laura, if Laura can pick that up before she goes?
It's not Elizabeth, it's me.
No, it's Elsie.
Okay, Elsie.
Yeah, I'm just asking Laura. Thank you so much, Laura, for this enlightening talk. Honest, it's a bit frightening and it's just stunned me. You just talked about the food plan. Are they thinking of rolling it out? How can one get on it, or are GPs informed about this so that they can put clients in the community on this plan?
So NHS England have realised how well this actually works. So it started in Newcastle, so yes, it will be rolled out throughout the country. So our patients had to pay for their shakes, and it is £40 a week for their shakes. I think they got £10 off, but the NHS one will be free and they will be supported. Different areas are going to do it differently, and so you just need to watch that space, I think, because COVID has delayed everything. But as things start to go back to normal, then yes, it will definitely be rolled out, because this gives people back their lives again. It's amazing. Yeah.
Thank you so much for that.
Okay, thank you. This is the point where, Laura, we all give you a virtual clap.
Oh, thank you
so much.
Bye. Bye. Thank you very much for asking me.
Thank you very much, Laura. Thank you.
Merry Christmas. Thank
and
you.
And to you all. And to you all. Take care. Bye-bye.
Bye.
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 Laura.
Okay, that was a very, very good. Thank you, Evodian. So just for us to recap, we don't have any presentation for January, because January meeting we're going to use to focus on preparation for AGM for February. The next time we'll have a presentation will be March, and that would be myself. And then please, 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 if people can forward their topics to Evodian, or if you have guest speakers on relevant topics. I'm sure we all work with some fantastic speakers. So you could give them a nudge and ask them if they can spare half an hour for us. That would be helpful. So thanks Evodian. Thanks a lot.